Welcome, everyone. My name is Dr. Jean Elwing, and I'm a professor of medicine and the director of the Pulmonary Hypertension program at the University of Cincinnati. And I am here to talk with you about common questions in pulmonary hypertension, looking at novel therapeutic approaches to this disease. So let's talk about the guidelines and what they mean to us. And I'm going to go through some questions. So the first question I want to ask is, are there any new studies reviewing the use of combination therapy in pulmonary hypertension? Well, yes, there is. But before we do that, let's talk about the guidelines and how we use them. Okay, guidelines are what they are. They guide us. They're not an end-all be-all, but they do help us understand how to assess patients. And the 2022 ERS-ESC guidelines are extremely helpful, and they give us a lot of detail on what patients to look for and how to assess those patients. So we see a patient, we think they might have pulmonary hypertension, we evaluate them, and then we diagnose them. After we diagnose them, we risk assess. We find out how severe their illness is. And if that illness is mild, on the low risk side, or even intermediate, we're going to start with combination oral therapy. Those patients who are high risk from the beginning, we're going to give them oral therapies in addition to parenteral prostacyclins, and then regularly reevaluate. So those low and intermediate patients, we want to drive them all to low risk if we can possibly do that. But if they don't reach low risk, if they're in the intermediate risk range, we're going to evaluate them further and figure out, are they on the lower side of intermediate or the higher side of intermediate? If they're on the lower side, we are going to give them their additional therapy with a prostacyclin pathway agonist, or we're going to switch out the phosphodiesterase inhibitor, the PDE5, for a guanylate cyclase stimulator. Now, if they are on the higher side of intermediate or high risk, we'll opt to add a parenteral prostacyclin. So again, just a guideline for most of our patients. But how did we get to these guidelines? Well, let's talk about that. Historically, we know that combination therapy has been looked at in multiple ways. The biggest driver of combination therapy to date has been the AMBITION study that showed us the combination of tadalafil and ambrisentan together delayed worsening and improved outcomes in our PAH patients. That was the AMBITION study. But in addition to that, we have learned a lot from other studies. One meta-analysis recently published, looking at more than 800 patients, showed us that we had a marked reduction in hemodynamics with combination therapy, with a more than 50% reduction in PVR from baseline when patients with new diagnoses of pulmonary hypertension were given combination oral therapy. So important information. And we get that from a number of studies. One study that's important to mention that has been recently completed told us a little bit more than just hemodynamics. The REPAIR study, patients were on PDE5 therapy, phosphodiesterase inhibitors, or no therapy, and macitentan, an endothelin receptor antagonist, was added. And what did we show? We showed that right ventricular stroke volume improved with that intervention, and pulmonary vascular resistance decreased. Two important things, but it was more than just the PVR. We saw structural improvement and hemodynamic changes with this intervention. So very important, also helping us understand that we could use some different markers of improvement in studies going forward, including echocardiogram and, in this study, cardiac MRI. All right, now I want to mention that change in PDE5 to guanylate cyclase that I mentioned in the guidelines. When those patients were not reaching their low risk status, they were in that intermediate status on the low side, that you could switch therapies from PDE5 to a guanylate cyclase stimulator. Well, this has been looked at in a few studies. One was the RESPITE trial. This looked at an open label approach, switching PDE5 to guanylate cyclase stimulator. And they saw that some patients, more than 30%, had a robust response and improved overall with our classic markers of walk distance, functional class, and worsening. And they tried to figure out who would respond. Well, the interesting part of this is that even if you didn't meet that 30% of patients where they improved, the majority of patients had improvement in cardiac efficiency and stroke volume index, irrespective of your responder status, telling us that we need to always look at the one level, but also a level deeper at how we're affecting our patients with medications and medication optimization. So that was one thing I thought was very important to be aware of, that we're not only affecting those routine markers, but additional findings on imaging. Another study that I think is important to mention is the REPLACE study. The REPLACE study looked at patients who were on PDE5 therapy and an ERA, and switching that PDE5 to a guanylate cyclase stimulator. And patients were randomly assigned 1-to-1 to remain on their PDE5 or switch to riociguat and followed for about 24 weeks. The primary endpoint was met in about 40% of patients in the riociguat group and only 20% of the patients in the PDE5 group that they were improving in 2 to 3 variables, walk distance, functional class, or NT-proBNP. So we showed that we had more patients improving if they were able to switch to the guanylate cyclase stimulator. This is supporting that change I had mentioned in the guidelines when patients are not reaching that low risk status after they're given 2 drugs up front. So just to understand the basis for that. Another study I'd like to mention, which I think is very important, and you may not have heard of, is the ADUI study. That was looking at tadalafil, which is a PDE5 therapy, and that being used with an ERA, macitentan, in newly diagnosed patients, trying to see if this combination of medications could lead to improvement. And they found that at 16 weeks, there was improvement in PVR as well as 6-minute walk distance. And this has led to the development of a combination therapy, a combination pill for our patients, which may be available to us in the near future. So we're looking forward to that. And I think this study was very important to show us that this combination was able to lead to those positive effects for our patients. The last study I want to mention is the Freedom EV open label trial. This looked at oral treprostinil compared to placebo, and they followed patients a long time in this open label extension. And what they found was those patients who were exposed to oral treprostinil versus placebo had a 36% reduction in death at study closure, something that was very thought-provoking and increased our awareness of this possibility of adding this prostacyclin pathway in an oral form to our patients who are not meeting that low risk status. Now on to the next question. Should we be initiating our patients with triple versus double therapy? Triton was negative for upfront triple therapy compared to double therapy at diagnosis, but guidelines steer us toward the potential of triple therapy eventually. What does that mean? So this is a complex question because we know that Triton was negative, but we're not talking about triple therapy in many of our patients in the guidelines. This is a different group of patients. The Triton study is looking at newly diagnosed patients upfront triple therapy. That's a very different patient than the patients going through the guidelines, hitting those high risk status, and then we're going on to triple therapy with a parenteral prostacyclin. This is a unique group of patients, newly diagnosed, assessed, and started on 3 drugs. What did we find in this study? It was wonderful that we found that 2 drugs and 3 drugs dramatically impacted hemodynamics with more than 50% reduction in our pulmonary vascular resistance. So we said, yes, 2 drugs and 3 drugs work very well. But there were some signals I think we should be aware of. And one that was interesting and presented is that there was a 41% reduction in risk of disease progression when patients were exposed to that triple oral therapy initially. So this also is something we need to be aware of and needs to be studied further, because this could be impactful for our patients, not in that short-term hemodynamic change, but in the long term in terms of their outcomes. So I'm sure there's going to be more to come on this question. So another question is, how does this impact survival? So combination therapy is the name of the game for all of our patients. Triple combination therapy is what is needed for our sickest patients. If you look at the French registry, you can see outcomes of those patients on monotherapy, double therapy, and triple combination therapy. And the sickest patients got triple combination therapy with parenteral prostacyclins. And if you look here, the survival up to 5 years is more than 90% when patients are treated very aggressively. So just reminding us that when we are treating a PAH patient, we need to risk assess and treat to that risk and drive that risk down. And we can impact how long people are surviving with this illness if we do that. But we have to really give it 100% and really watch these patients and reassess and add therapies if we need to. So the next question is, what is the timing and role for parenteral therapy? Should we reserve it only for our sickest patients or initiate it earlier in select cases? So that is a very important question too. We talked about using it in our sickest patients, and let's review that information from the French registry again. We saw that patients who were exposed to more medications were the sickest patients. They had the highest risk, but they were able to achieve that very good outcome. So are we really undertreating some of our intermediate risk patients? I think we will find that out over the next short period of time. And we may want to offer more aggressive therapy to some of those higher intermediate risk patients even earlier than we are. So I think we have more to learn here, but for now, we are using our triple therapy with parenteral therapy in our highest risk patients, hitting that disease very hard, and we are able to impact outcomes by doing that. So very important information we've learned from the French registry at 1 year, 5 year, and 10 year, with a 10-year 86% survival in those patients who we previously would have felt would not have been able to survive to that 10-year mark. So our next question is, how are you using parenteral therapy? How am I using parenteral therapy? Well, good question. Trying to follow the guidelines, trying to use these medications as well, safely, and as aggressively as patients will allow to improve outcomes. But we've been looking at different ways to assess, address, and use these medications over time. One study I would like to mention to you is the Artisan trial. This is a newer trial you may not have heard of. This is a study where we're looking at patients who are prostacyclin naive, starting them on treprostinil, either IV or subcutaneously, driving down pressures, and we're going to monitor that by cardiac MRI and by cardiomems. The cardiomems, we're going to be watching pressures. Cardiac MRI, we're going to be watching heart function. And then when patients meet our key markers, we're going to try to transition them to oral therapy. Why? Because patients want to feel better. They want to survive longer. They want to be more functional, but they want to do that with the most user-friendly medications. And so this is an approach that is novel, using cardiomems to watch pressures and watch us drive those pressures down with medications to allow us a switch to an easier form of therapy. So more to come on this. This study is underway. So another study that I think is interesting and thought-provoking is the EXPEDITE trial. This study was recently completed. This looked at patients who were prostacyclin naive, starting them on treprostinil, and then rapidly increasing and then switching to oral therapy and seeing if we could achieve doses that we felt were effective doses for our patients. And this study has allowed us to learn a lot about how to transition patients, how people in the PH community are using these medications, and may provide a guide for others to do the same for their patients who are interested in getting to oral therapy eventually with their pulmonary hypertension. So again, we want to treat our patients aggressively, but we want to give them the options for easier to use medications if possible. Our next question is, can we wean from parenteral therapy? Well, we've learned a lot about this also. We are able to do this. If we went back in time a few decades, the answer would have been no. And gradually over the last several years, we're getting more and more comfortable that we can start a patient on infusion therapy, stabilize their disease, reassess, and if they are one of the people that has a very good response, they improve, their right heart function improves, their pressures come down, they could be a candidate for transition to oral therapy or inhaled therapies. So this is not a forever medication for everyone anymore. There are people that will benefit from lifelong infusion therapy, but for those who improve and would like to change to a different therapy, I think we can say it is a possibility. So very good news in that regard. The next question is, how close are we to personalized medicine in pulmonary hypertension? Well, I would argue that we are already doing it. We are not putting every patient in that guideline and saying, we're going to get 2 medications, we're going to come back and get 3 medications, and then we're going to switch this medication at the 4th visit if we're not to where we want to be. We are actually risk assessing, and we're determining medications based on that individual risk. And with that information, we have choices in each group of medication, and we pick medications based on the personality of the medication and that individual patient. So we are doing some individual and personalized medicine, but we definitely could do more. So what do we have to work with? Well, we have our risk assessment tools, but we are doing amazing work understanding and phenotyping patients in many big centers that are following PAH patients. So what do we hope for? We hope at some point it'll be easier to detect and diagnose PAH patients, but for now, we are using our clinical skills, our history, and our standard testing, including right heart catheterization. And we're hoping to have better biomarkers. Right now, we have BNP and NT-proBNP, which are wonderful. They tell us about stress and strain on the right side of the heart. But in the future, we would love to have a biomarker that's telling us about early changes in the pulmonary vasculature. We would like a biomarker that tells us if that patient would respond to one medication versus another. And we would like a biomarker that we could follow in high-risk patients that tell us if they're likely to develop disease. But I'm hopeful that will be in our near future, but not quite ready for prime time yet. So another area that's exploding is personalized medicine using genomics and genotyping and phenotyping those individuals. And this is an area where I think we will really benefit from over the next decade. I'm hoping that we can say this patient with this genetic change would benefit from this medication. And if they don't benefit from that medication, we would add this one. That would be ideal. If we could have a roadmap for individual patients that would lead us to best outcomes, that would be something we could really, really make an impact on outcomes in our patients. It's not here yet, but we are doing such great work at many centers, learning more about these individual patients and not really this big framework we have now of this man-made groups of pulmonary hypertension, but really understanding individual subgroups that would react differently to different interventions. But I have to say, we are doing a great job in our PAH patients, but we have a lot of work in the pulmonary hypertension patients in general. In the Compare registry, we showed that our survival is much better than we would have had 20 years ago. But I do have to say that we have a great deal of work in pulmonary hypertension in general. We have made great strides in pulmonary arterial hypertension. We understand how to risk assess. We understand how to start medications, continue medications, and reassess. But our patients who have lung disease or other comorbidities with their pulmonary hypertension don't have as good of outcomes. So we need to better understand those unique patient groups, really dig deep and see if we can change their overall outcomes by modifying how we address and treat them. So great deal of work to do there, but I am sure we are going to get there because we're really working hard on better understanding pulmonary hypertension patients, better phenotyping, genotyping, and then hopefully we'll get to a personalized approach for patients. All right. Our next question is, with the emergence of novel therapies, how do we ensure universal access to all of our patients? Well, this is critical. We can be amazing at taking care of PAH patients, but if we can't do that for all of our patients or offer that to the vast majority of our patients, we are missing a positive effect on a segment of our population that really needs us. So we've got to be aware of social determinants of health and how they can negatively affect our patients. And in a recent VA study, they showed that lower socioeconomic status impacted the time for initiation of medication and significantly negatively impacted that. So we need to be aware and we need to address these things as we are able, so all patients can have that ability to be treated and followed the way we want all of our PAH patients to be assessed and treated. Another question that we have is, can you discuss any studies reviewing the use of new therapies in patients with pulmonary arterial hypertension? Well, let's talk about this. This is a very exciting time. We're looking at multiple different pathways: the PDGF, serotonin, mTOR, activin, and the BMP pathway. So let's start by talking about that BMP pathway. Let's talk about the STELLAR study. This was recently completed looking at sotatercept in PAH patients. Well, let me give you a little background. Dysfunctional bone morphogenic protein, BMP, pathway signaling is associated with both hereditary and idiopathic subtypes of PAH. It's a novel fusion protein and it binds activins and growth differentiation factors and attempts to restore balance between growth promoting and growth inhibiting factors. So we're trying to restore the balance that is off in patients with pulmonary arterial hypertension. So in the STELLAR study, 320 patients enrolled, and it was a phase 3 double-blind study, and they found that it met its primary endpoint of improved exercise capacity based on the walk distance. So those patients exposed to sotatercept had significant improvement in walk distance at 24 weeks. In terms of secondary endpoints, it looked at 9 secondary endpoints: a multi-component score, a PVR, BNP, functional class, time to clinical worsening, the French score, and 3 parts of the PAH SYMPACT score, looking at physical impacts, cardiopulmonary impacts, and cognitive and emotional effects. And this study showed us that sotatercept had a positive impact on 8 of those 9 secondary endpoints. The only one it did not meet was the PAH SYMPACT cognitive and emotional effects. So important to know, it had multiple impacts on these patients that were evaluated in the STELLAR study. It was also important to note that they looked at time to first non-fatal clinical or worsening or death. And in the patients who were exposed to sotatercept, the time to these events were delayed as compared to those patients who were exposed to placebo. Also a very important finding. So how did patients tolerate this medication? Well, overall, quite well, based on what we learned about the adverse events. Adverse events that occurred more frequently in the sotatercept patients than placebo were related to epistaxis, dizziness, telangiectasias, increased hemoglobin levels, thrombocytopenia, and increased blood pressure, with the most common adverse event that happened in terms of bleeding being epistaxis, with 20% of those patients who were exposed to sotatercept experiencing epistaxis. So just important information to have, but overall found this medication in the study to be fairly well tolerated. Another very important area that's being studied for pulmonary arterial hypertension is the tyrosine kinase pathways. And it's important to understand that these may play a very pivotal role in the development of pulmonary vascular disease. Pulmonary vascular intimal lesions and medial wall thickness are changed in our patients, and growth factors are playing a role. Imatinib is a competitive inhibitor of a few of those tyrosine kinases that are involved in the development of these vascular changes. And it has been reported to have had a dramatic effect on a small number of patients with PAH. And because of that, it was attempted to be studied in the past, but was limited by some safety issues. So recently, they've looked at different ways to deliver these medications, and a phase 2 clinical trial called Positioning Imatinib for Pulmonary Arterial Hypertension is underway in the UK to determine what is the tolerable dose and how do we discontinue it if we have side effects, and can it impact PVR, pulmonary vascular resistance. So that is one thing that's underway. And they're also looking at different ways to deliver tyrosine kinase inhibitors and seeing if we could more safely treat patients and reduce side effects by different delivery methods, like inhaled. And they're studying imatinib in an inhaled study for PAH and PH-ILD, and this is being evaluated at this time. So more to come on that. Additionally, there's a phase 2 study called the TORREY study that was recently completed, and it looked at seralutinib, which was an inhaled TKI that is a small molecule and an inhibitor of platelet-derived growth factors A and B. And they found that it led to a 14% improvement in pulmonary vascular resistance and a trend for improvement in walk distance. And phase 3 of that study is going to be initiated in the very near future. So more to come on that agent also. Another thing that is being looked at is different ways to deliver our current medications. And one is liposomal treprostinil. We're all familiar with inhaled treprostinil, which is a 4 times daily inhaled medication. But when given in this liposomal form, it is inhaled to the lungs and then released into the lungs in a more stable way. And it is reduced in its frequency of delivery to twice daily. So currently they are studying this in a phase 3 study, looking at if we can transition patients from inhaled treprostinil to this liposomal delivery system and seeing if this may be an option for our patients going forward. So this is underway at this time. So again, more to come on this delivery system. The last study I want to mention to you is another way to deliver inhaled treprostinil as a dry powder. And that would be delivering the treprostinil as a prodrug. And this would allow you to reduce the frequency of the dry powder inhaler to once daily and allow that even distribution and even levels of this medication in the body over time. Results were announced from the phase 1 study in 2022, looking at 42 healthy volunteers, and now going on to additional studies in pulmonary hypertension patients. So exciting option that may be available to our patients in the future. Thank you so much for joining me in this discussion of novel therapeutic approaches in pulmonary arterial hypertension. I so appreciate your time, and I hope you enjoyed the discussion of these questions. In summary, we know that there are several clinical trials that are helping guide us. We know that upfront combination therapy has shifted our treatment and improved our patient outcomes. And we keep learning more and more about how best to use our medications together. Additionally, we're studying several agents that may positively impact our patients in the future. And finally, we are working to better understand the phenotype and genotypes of our patients so we can individualize our approach to each patient for best outcomes. So with this, I'd like to say thank you and ask you to please complete your evaluation so you can get credit for this activity and give us any feedback you might have to improve for next time.